Okay, so I'd like to go ahead and get started. I'd like to talk a little bit about the differences between previous lectures and bones. And then there's a recent article that I saw in the American College of Radiology journal, which talks about how to differentiate low, low and high risk findings on plain films concerning neoplastic disease. So in 2002, as we talked about, there's a division of tumors, bone tumors and cartilage tumors, osteogenic tumors, and so forth. And then in 2020, it's a very similar classification, but came out. But here they take the chondrogenic group and then divide them into those which are benign, intermediate, and malignant, which I think is a useful classification of the different lesions. And this also fits in with the article that I'm going to review at the end of this short little talk. So we talk about chondroid lesions, osteogenic lesions, also the benign, intermediate, and malignant classifications of osteogenic lesions, fibrogenic and vascular, also benign, intermediate, and malignant, as well as the osteoclastic giant cell rich, where basically you have intermediate giant cell tumors and malignant giant cell tumors in addition to the benign lesions we're familiar with. And then the same with notochordal lesions, just benign or malignant, and then other mesenchymal tumors of bone, which we've talked about. And then finally, there's the undifferentiated small round cells, and these are all malignant sarcomas. So let's now talk a little bit about this paper that came out in the Journal of the American College of Radiology, which is basically a review of things that you already know, but it kind of puts them into a classification that I think can be useful. And this was entitled Bone Tumor Risk Stratification and Management System, a consensus guideline from the ACR Bone Reporting and Data Systems Committee. And here, what they do is they take 6 different criteria of evaluating a lesion on plain films, assign numbers to them, add up the numbers, and then that gives you a score which can be divided into low, no risk for malignancy, low risk, intermediate risk, and high risk. Very similar to BI-RADS and PI-RADS and other RADS that are out there to help people. So they use evaluation of the margin, whether or not there's periosteal reaction and the kind of periosteal reaction, if there's endosteal erosions, mild, which is just very minimal, moderate, or mild is within less than a third of the depth of the cortex, moderate is a third to 2/3 of the depth, and deep is greater than 2/3 of the thickness of the cortex, whether or not there's a pathologic fracture, whether or not there's an extraosseous mass, and whether there's a history of primary cancer. So then you can assign numbers to each of these, add them up, and if it's greater than 7, it's highly likely to be malignant. And it will, in fact, here's basically the point system. If you have 1 or 2, then it's low risk, very likely to be benign. 3 to 4 is low risk, probably benign. 5 to 6, intermediate risk, potentially malignant. And we'll have a chart later as to what they recommend doing if people are in these different categories as far as follow-up and evaluation. And the 7 or greater is high risk, highly suspicious for malignancy. So first, looking at the margins of the bone, and you're all probably quite familiar with this, looking at different scoring systems. But basically, there's 1A, which is you have a sharply well-defined lesion with sclerotic margins. 1B is a sharply defined lesion with the margins sharply defined but no sclerosis. And another one where you can see the margins of the erosion, so it's a geographic type lesions, but the margins are ill-defined. And then you've got kind of a mixed lesion, which is called 3A. Then you have a lesion where you don't have well-defined margins. They're very irregular and difficult to draw a pencil around. That would be 3B. And then 3C is basically a lesion that's there, but mostly non-visualizable by X-ray techniques. And these tend to be the most aggressive. Then we go into periosteal reaction, and this is typically graded as none, non-aggressive or aggressive, in which none gets 0 points, non-aggressive gets 2, and aggressive gets 4. And here, so the non-aggressive patterns tend to fuse directly with the cortical bone, just kind of outpouches of the bone. You can have some little fissures in it. It can be lumpy and bumpy, but these are typically non-aggressive patterns of bone. So this is now looking at the aggressive patterns. This would be non-aggressive, nice and smooth, contiguous with the cortex. Then you can have a striated appearance where you have sclerosis, less density, more sclerosis, less density, and a laminated pattern. This has to do with different rates of growth and ossification over time. And this is characteristic of some malignant lesions, such as some osteochondromas, but it's also a classic finding that you can see with osteomyelitis. But it's more of an aggressive type lesion. And then you've got ones where you have calcifications that are basically stand up perpendicular to the cortex, called hair on end, and then a much more sunburst type pattern. And these are very aggressive lesions, typically seen in malignancy. And then more complex lesions of the two, which are also would be high risk and high aggressive for malignancy. So when you get this, you can add up the scores. If the lesion is a very low risk lesion, then if it's pathognomonic of lesions that we know are benign lesions, like a lot of the unicameral bone cysts and other things, you can just describe it and forget about it. Some of these are classic do not touch lesions, like the traction injuries, the gastrocnemius origins behind the distal femur. And these can be things like non-ossifying fibroma, osteoid and so forth. So you can just forget about them, or you can do an annual surveillance just to make sure that it's stable. Then there's the low-risk group, 3 or 4. They're typically asymptomatic lytic lesions without suspicion for periosteal reaction or deep endosteal erosion. A lot of these will have typical locations, which will be helpful. Examples are chondroblastoma, giant cell tumors, and aneurysmal bone cysts. If you see these, typically you'll get 3 to 6 months follow-up evaluation to see if there's any growth. If there's growth, then you're more concerned about it, and you'd probably go on to more advanced imaging or biopsy. But even with these, and generally, it's best to err on the side of caution. If you have any concern, suggest a biopsy or orthopedic oncology referrals. Then there's the intermediate risk, 5 or 6, typically geographic lesions with a known malignancy elsewhere, or geographic lesion with ill-defined margins. And these need to be followed up by further imaging and possible referral to oncology and biopsy. And then there are the high-risk lesions, which basically you see a big mass blowing out the bone, extending into the soft tissues. Though there are a few of those lesions which we've seen in lectures, which can be benign, but most of those are going to be malignant. And these need orthopedic referral and advanced imaging. So just show some examples, and these images don't come across very well because I just took photographs of this article. This is a lesion which basically has sclerotic margins, no periosteal reaction. So you get a 1A for the margins. Everything else is a 0, so it's a 1, so it's a very low risk, which we see here. And this was a non-ossifying fibroma and has a classic appearance. So one that you basically a leave me alone lesion. Next patient here, we can see it looks like there's some kind of sclerotic margins, but there are a lot of margins that aren't as well seen. Again, these are not great. They went ahead and did more advanced imaging, and we can see that it's a sharply defined lesion here. But when you go to the fluid sensitive images, it looks like it's fluid here. Contrast, there's a little bit of enhancement around the margins, but nothing in the side. And this turned out to then be a 3 as far as margins, a 1 as far as endosteal erosion, and so it's a 4, kind of a low risk. This turned out to be a unicameral bone cyst. Now, this is someone who had prior, as you can see, internal fixation. We can see that there's a lesion right in through here. Margins are kind of sclerotic. You don't see it very well here, but there's a periosteal reaction over here that's a little bit laminated deep to the bar here. If we scored this one, the margins were thought to be 1. The periosteal reaction they thought was more aggressive, is kind of the laminated type. Endosteal erosion, I thought that there was a little bit of narrowing, thinning of the cortex right in that location. Total of 5 points. And they followed up on this. This turned out to be an infection, an osteomyelitis within the bone, a little abscess in the bone. And then finally here we can see a lesion, kind of ill-defined margins, kind of marked thinning of the cortex, and we can see there's a pathologic fracture here. So the margins were worrisome, pathologic fracture, a total of 7 points, and so this was worked up, and I think this was a malignant lesion, but I forgot. Should say in here, I forgot what the diagnosis was here in reading the paper. So that's kind of the way it works. They recommend using this as kind of a bone rad system to score these for possibility of malignancy. Okay. I'm going to cut out and come back in again, Robert and Tayson.